Hi, this is Brian Kim. I want to share with you case number 176 in the best way to do cataract surgery series. This is a fairly dense lens, and you're going to see terminal chop and cross chop and using mechanical fracturing forces to crush the lens into smaller pieces. I'm able to conquer the posterior plate because of the terminal chop technique. I'm able to fracture through and through, and this gives me tremendous confidence that I will not encounter a posterior plate doing it this way. And I'm able to reduce ultrasonic energy and have clearer corneas post-op day one. So you can see how dense this lens is, a pretty dense cataract. This is a left eye. You can see the patient's having a little bit of a Bell's reflex issue here. Trying to help steady the eye with a cotton tip and using the corneal marker, which will hopefully help me to center and size the rhexis. Trying to ask the patient to look down, holding the eye with a cotton tip. The patient's resisting me because of that Bell's reflex. I'm able to still nonetheless get a nice flat approach with my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral epinephrine, and then some intracameral air, and some trypan blue. Filling the eye with dispersive viscoelastic, removing the trypan as well as the air. Using the Orlock technique to turn the eye downward a little bit because this patient's having a little bit of trouble. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then turn the eye towards me, and then I enter. Again, a little bit of a Bell's reflex with this patient. We'll do the best we can. These are the sharp tip Haldey-Perkar forceps. You see I'm using the cannula to Orlock the eye and turn it down. Puncture the center with the sharp tip forceps, grabbing the right side of the tear, going around circumferentially, trying to get a well-centered and sized rhexis based on the corneal mark that I made. Again, the patient's resisting me quite a bit here, having to reposition the cannula to turn the eye. So, there's a lot going on in these cases. You could do a block on these patients, but there's risks with block as well. So I have these maneuvers and techniques to help me get through these situations when the patient's having difficulty cooperating with the surgery. Able to finish off the rhexis to get a nice sized and centered rhexis there. And this is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, decompress on the left side, sweeping the anterior capsule on the left side, turning the cannula on the right side, and the lens begins to spin. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Now I have 2-point fixation, and I should have much better control of the eye, despite the Bell's reflex. Removing the surface epinuclear material. I'm going to turn bevel up now. I switch to sculpt mode, and I'm going to start sculpting the center. And you want to create a nice central trough. You want to get through the bulk of that central core, that dense core, with the technique. You don't want to go all the way down to the posterior capsule. You don't really need to do that with this technique. So I get a nice groove, and then I go to bevel down. I place a chopper under the rhexis edge contra-incisionally. With terminal chop, I fracture from the edge, the equatorial side, and that chop propagates all the way through. You can see I'm through and through now. Placing the chopper under the right heminucleus, rotating the chopper vertically, crushing the lens against the phaco-tip, just like a chopping block, and it fractures right heminucleus completely in half. placing the chopper around that first quadrant, crushing the lens completely in half between the instruments, and then emulsifying the lens piece. So I'm going to show you that one more time. Again, after I've made my groove, I place the chopper under the rhexis edge contra-incisionally. I'm bevel down now, and I'm going to fracture the terminal side. Again, I'm getting that equatorial lens that's chopped. Once it's chopped down there, that means it's all the way through and through. That fracture point is through and through, and I'm able to propagate and spread that tear all the way down that fissure, and I'm able to get through and through completely. And again, this really bypasses any potential for a posterior plate. I place the chopper around the right heminucleus, pulling it centrally toward the phaco tip. And again, the phaco tip is acting like a chopping block, and I'm able to fracture that right heminucleus very easily now, using some vacuum to pull that first quadrant up, getting the chopper around the lens, crushing the lens between the instruments, using mechanical forces, using some vacuum to position the lens a little bit easier, and then fracturing the lens completely in half. So I do use a little bit of vacuum sometimes if the lens is sitting wonky. I'm able to grab it a little bit, and then I lay off of the vacuum and then use mechanical forces to crush the lens. Once I do this, I emulsify that first quadrant completely, and again, using mechanical forces to crush the dense lens pieces. By doing it this way, I'm able to utilize less ultrasonic energy and just pulse the ultrasonic energy in vacuum with this technique. Positioning that second quadrant in front of me, placing the chopper around the lens, crushing it completely in half, using some vacuum to grab that fragment, crushing the lens between the instruments, and once the pieces are small enough, emulsify the lens piece. As you can see, the CDE is high, but that CDE was really primarily used during the sculpting of the lens. Again, using some vacuum to position that fragment on the tip, and then crushing the lens between the instruments, and then emulsifying the lens. Turning the second heminucleus in front of me, placing the chopper around the lens, positioning the phaco tip fairly deep. Again, this is a dense lens, fracturing it completely in half, getting the chopper around that third quadrant, hooking the peripheral lens, crushing the lens against the phaco tip. Again, it's like a chopping block. The phaco tip is like a chopping block. It fractures the lens very easily and efficiently, and then using crushing forces to crush the lens pieces into smaller and smaller pieces with the instruments, and then emulsifying the lens piece when the pieces are small enough. Again, after the sculpting was done, I think the CDE was around 6 or 7. Now it's around almost 9. So really with the lens disassembly part, otherwise, I probably used around 3 of CDE. Crushing this fourth quadrant with mechanical fracturing forces, crushing the lens between the instruments over and over again, and then utilizing ultrasonic energy and vacuum, especially with this last piece. You want to protect the posterior capsule. I'm very ginger about pulsing with the ultrasonic energy and vacuum and using mechanical forces to crush the lens into smaller pieces before I try to go aggressive with the ultrasonic energy and vacuum. So that's kind of how I like to do it. Use mechanical forces to maximally crush the lens, and then using pulses of ultrasonic energy and vacuum. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the I&E handpiece. Always start sub-incisionally, trying to peel the cortex from anterior to posterior. You can see this is a fairly stiff sheet of cortical material. It's probably like cortical material mixed with peripheral epinuclear material here. This is fairly dense, it's not going in, so I'm going to use the cannula to mash that tip. There must have been a dense fragment that's caught at the tip, using the cannula to mash the tip so that it clears that material. Switching to cortex mode, making sure I'm peeling and removing the cortical material from anterior to posterior. And I'm using foot pedal control to modulate when I go near the capsule. I've learned over the years the vacuum is so strong, you can actually grab the capsular bag when you're doing the cortical removal. And so again, you want to be mindful with foot pedal control how much vacuum you're utilizing. you want to only remove the cortex and really grab the cortex. You don't want to grab the capsular bag. And then when you have to do fine work, you drastically reduce that vacuum down with polish mode, and you're able to polish the posterior capsule, polish underneath the anterior capsule as well, removing lens epithelial cells, removing any stubborn, wispy cortical fibers that are there as well. And so that's really when you use a fine work and you're really up against the capsule, you don't want to grab the capsule, use polish mode for those steps. Pulsing into the subincisional capsular fornix, you can see some liberation of lens material here. There you go. You can see there's stuff coming out. And go after it with some vacuum. Switch to cortex mode, clearing that material out. And then filling the capsular bag with some cohesive viscoelastic. And then using the capsule sweep to polish first in the subincisional area. You can see there's a bunch of stuff coming out. And that's the advantage of using the sweep. You can mechanically sweep out that material fairly easily and confidently. Again, the eye is filled with OVD. It's a very controlled way to clean the subincisional capsule fornix as well as the remainder of the capsular bag. Widening the incision with the blade. Again, this is a dense lens. They tend to have weak zonules in my experience, so I like to go with the 3-piece lens. Turn the bevel to the left, delivering the leading haptic into the bag. You can visualize it going underneath the rhexis edge, delivering the trailing haptic out of the eye, using the Maltzman now to deliver the trailing haptic into the bag. So both haptics are in the bag now. Go in with irrigation off, get underneath the lens, activate irrigation, removing the viscoelastic from within the bag. Being very careful, trying to tease and polish the subincisional area there. Switch to polish mode, turning the lens. Sometimes in these 3-piece lenses, or even the 1-piece lenses, the lens doesn't center quite well. And obviously the lens is symmetrical. So it's not the lens. It's really, I think, variations in the patient's capsular bag anatomy. You know, everyone's built differently. And so the capsular bag is not perfectly round and symmetrical. And so as a result, sometimes the lens sits a little funny. And so part of the solution to that is to rotate the lens 90 degrees and see if it sits a little bit better. And so that's what I'm trying to do here, seeing if I can rotate the lens and see if it sits a little bit more centered, and it does now. And then after that, you remove all the viscoelastic and then you hydrate your incision. So again, this is a pretty dense lens, a cataract. You saw terminal chop, debulking the central hard core. You don't have to go all the way deep. You don't have to really depend upon a red reflex when you're sculpting. You don't have to do all that stuff. Just debulk it first, again, and then place the chopper around the rhexis edge at the equatorial side. Fracture that part of the lens. And when you fracture from the equatorial side, it begins that crack and tear involving the posterior aspect of the lens. So once you fracture that, it's like a Pac-Man. You can open the jaws of the Pac-Man and it propagates and tears that fracture point all the way through and through. After that, you perform successive cross-chop maneuvers throughout the case, very confidently and efficiently disassembling the lens with varying vector forces with the cross-chop. Again, you can chop it from any angle because of the technique of the cross-chop, which is very versatile. You never feel like you're stuck, and you never have to spin the lens when you're feeling like you're stuck. And so you can just perform cross-chop, and then once you disassemble the lens piece, again, you're using the chopper to pull towards the lens material, crushing it against the phaco tip, which acts like a chopping block. Remember, you're not using vacuum or ultrasonic energy to hold the lens in this technique. You're just using it as a chopping block as leverage, and then you're able to crush the lens against the phaco tip. That's the beauty and elegance and the nuance of this technique that unless you do the technique, you really don't understand that. You don't understand the power of it. And that's why I'm able to very confidently disassemble the lens, even if the lens doesn't spin, even if there's loose zonules. I'm able to efficiently fracture the lens from any angle without any fear or worry. Once you do that, you can fracture the lens into smaller and smaller pieces by crushing the lens into smaller bits. And then once the pieces are small enough, using pulses of ultrasonic energy and vacuum. Again, this case, I use most of that ultrasonic energy during the sculpting, which is around 6 or 7. And you can see the CDE is 9.14. And this patient had a nice clear cornea post-op day 1, reduced ultrasonic energy, happier patients, more of a wow factor with your patients. And so this is why I believe this is the best way to do cataract surgery, in particular for the cataract, the dense lens. So I hope this was helpful to you, and I thank you for your attention.